Hello and a very warm welcome to this advanced clinical explainer. Today we're diving deep into the genuinely fascinating and complex world of perioperative management in thoracic surgery. Specifically, we'll be taking a highly detailed evidence-based look at the use of bronchial blockers in patients requiring one-lung ventilation. Whether you're routinely managing lobectomies or you frequently find yourself navigating incredibly difficult airways in the critical care setting, mastering the subtle nuances of these devices is just absolutely crucial. We have a lot of robust clinical data to get through, so let's get straight into it.
Good to see you. I would like to express my gratitude to the specialists in thoracic surgery, anesthesiology, and critical care medicine for your dedication to anesthesia and perioperative management in thoracic surgery. Today, we will discuss the use of bronchial blockers in patients requiring one-lung ventilation.
こんにちは。胸部外科手術における麻酔および手術期管理に尽力されている胸部外科、麻酔科および集中治療医学の専門家の皆様に心より感謝申し上げます。本日は片肺換気を必要とする患者様における気管支ブロッカーの使用についてお話しいたします。
Right, let's have a quick look at our agenda for today. We'll kick things off with an overview of one-lung ventilation and the historical evolution of blocker devices. Then, we'll dive deep into the specific architecture of individual blockers, explore their life-saving applications in pediatrics and difficult airways, discuss positioning and complication management, and finally, we'll wrap up by breaking down the latest meta-analyses comparing blockers to double-lumen tubes. Section 1. One-lung ventilation and bronchial blockers overview.
Now you might be wondering, with the bulky double-lumen tube, or DLT, long established as the gold standard for rapid lung collapse, why focus so heavily on bronchial blockers? Well, the clinical indications for one-lung ventilation, whether it's major thoracic surgery, VATS, achieving absolute lung isolation, or protecting the contralateral lung from infection or bleeding, require immense precision. While DLTs are brilliant for rapid deflation, they can be notoriously rigid and cause significant airway trauma. The real game changer in modern practice is recognizing the clinical scenarios where bronchial blockers are vastly superior. We're talking about patients with known difficult airways, those who arrive in theater already intubated with a single-lumen tube, or patients suffering from severe subglottic stenosis. In these cases, swapping out a tube is unnecessarily risky, and slipping a bronchial blocker down alongside or through the existing airway is unequivocally the safer, more elegant clinical choice.
Section 2. Evolution of blocker devices.
The whole concept of lung isolation isn't actually a recent invention. The idea first emerged way back in 1936 with Magill's initial concept of bronchial blockade. But it really started gaining practical traction in the 1960s when highly resourceful anesthetists began using Fogarty vascular embolectomy catheters purely off-label. Then, 1982 brought a major leap forward with the Univent tube, which actually integrated the blocker into the tube itself. From there, we see this rapid sequential evolution of standalone devices. The Arndt wire-guided blocker arrived in 1999, solving massive positioning issues. The Cohen flex tip followed in 2005, and more recently we've seen highly specialized architectures like the Easy Blocker, the Fuji Uniblocker, and the Coupe Deck. Each of these devices was specifically designed to overcome the limitations of the last, giving us an incredibly versatile modern toolkit.
Section 3. Device Deep Dive. Let's look at the mechanics.
Let's start with the classic Fogarty embolectomy catheter. Now, structurally, because it was designed for vascular work, it has a high-pressure, low-volume cuff, and crucially, it's made of latex. It also completely lacks a suction lumen and a guide wire. So lung collapse with a Fogarty is entirely passive, which takes time. But its clinical utility is still remarkable. Think about a patient who already has a single-lumen tube in place, or someone with a tracheostomy, or a tricky nasal intubation. It's a lifesaver. In fact, Park and colleagues published a brilliant 2003 series detailing 5 cases of severe subglottic stenosis where standard tubes failed entirely and the Fogarty was successfully used to secure the airway. You can use it in both adults and pediatrics with sizes ranging from 3 to 7 French. The only absolute hard stop? You cannot use it in patients with a latex allergy. Next up is the Univent tube by Fuji Systems. The architecture here is incredibly clever. It's essentially a standard single-lumen tube, but it features an integrated secondary channel that houses a movable, torque-controlled bronchial blocker. You intubate normally and then advance the blocker. The clinical versatility here is staggering. For instance, In and colleagues reported a case in the Korean Journal of Anesthesiology in 2013 where they actually chopped the blocker off a Univent and used it as an isolated device for an emergency temporary OLV. And in 2010, Chin and his team utilized the Univent's blocker channel to deliver high-frequency jet ventilation directly to one lung during a complex carenal resection. Furthermore, when Hostin compared the Univent against the Easy Blocker in 2018, they found interesting variations in airway pressures and gas exchange, highlighting that the internal volume occupied by the Univent's channel does slightly alter airway dynamics compared to standalone blockers.
Moving on to the Endobronchial Blocker by Cook Medical. The standout feature here is its ingenious wire loop guide structure, which couples directly to your fiber optic bronchoscope. You essentially drive it to the exact spot you need. Now, regarding adult placement, specifically left versus right mainstem, a 2018 letter by Tollins clarified that the currently available adult ANT model uses a spherical balloon, not an elliptical one. This spherical design is actually brilliant for right mainstem placement, as it allows for a tight seal without herniating into and blocking the right upper lobe bronchus. We also have incredible case reports, like a 2015 JCVA paper detailing the extraluminal insertion of an ANT blocker directly through a tracheal stoma in a difficult airway scenario. And of course, Knoll's landmark 2006 RCT robustly validated its efficacy against traditional DLTs, proving the ANT's exceptional utility in complex cases.
Let's look at devices built for steerability, the Cohen Flex Tip and the Soaring Medical Coupe Deck. The Cohen blocker features this unique, rotatable wheel tip mechanism. As Cohen himself noted in a 2006 correspondence, this mechanical distal flexion makes navigating the sharp angle of the left mainstem remarkably smooth compared to standard blockers. But we do need to be mindful of trauma. Coaster-X 2013 retrospective analysis in the Auctioner Journal reviewed 130 Cohen blocker cases, specifically monitoring complication rates like vocal cord injuries, tracheobronchial trauma, and post-operative hoarseness, which, while low, are still a factor depending on operator technique. On the flip side, we have the Coupe Deck, which boasts a pre-formed distal angulation. Recent network meta-analyses have shown that the Coupe Deck actually holds a statistically significant advantage in first-attempt success rates for both pediatric and adult populations purely due to that pre-curved shape.
Now for something completely different structurally, the Easy Blocker. This is a Y-shaped, semi-rigid, double-cuffed device designed to simply sit flush on the carina, naturally dropping a blocker into both mainstems. Rispoli's 2023 practical guide drawing on 10 years of experience highlights its straightforward positioning. Vega's 2012 data showed incredibly fast insertion times, averaging just 76 seconds. However, it's not without its quirks. Double-Lumen's published a highly insightful 2022 report on a specific technical failure where air communicated between the two cuffs. This leak led to alarmingly high airway pressures, severe hypoxemia, and unintended inflation of the non-dependent lung. When we look at the RISA 2022 and Morissa 2013 RCTs comparing the Easy Blocker to DLTs, the data shows that while the Easy Blocker significantly reduces airway trauma and malpositioning, you still have to be hypervigilant about cuff integrity and the slightly slower lung collapse times.
Section 4. Pediatrics and Difficult Airways.
When we shift our focus to pediatric one-lung ventilation, the constraints change completely. The simple reality of narrow, delicate pediatric airway anatomy means that using a double-lumen tube is physically impossible in children under 8 years old, or roughly under 30 kilograms. It's just not an option. Your device selection must be strictly dictated by the child's weight, height, and internal tracheal diameter. This is exactly where specialized devices shine. A classic example is Vald's 2005 experience published in the BJA. They used the incredibly slim 5 French pediatric ARNT blocker in 24 cases for children ranging from 2 to 16 years old, achieving successful lung isolation in 23 of those 24 cases. That is a phenomenal success rate for such challenging anatomy.
But what happens when you're operating on an infant, where even a 5 French blocker might be too large? This is where we circle back to the Fogarty catheter. Comra's 2017 study detailed a brilliant technique using a rigid bronchoscope to manually place tiny Fogarty catheters in 27 pediatric patients, primarily for severe separative lung disease. We also have the 5 French Fuji uniblocker, which has proven highly effective. Chang's 2021 case series in medicine reported 3 stunning successes using the uniblocker in infants under 1 year old during uniportal VATS for congenital pulmonary airway malformations. The main takeaway from Chang's paper, however, was the absolute necessity of meticulous balloon dislodgement management, as even a millimeter of movement in an infant airway can compromise the entire surgical field.
Beyond pediatrics, bronchial blockers are the ultimate get-out-of-jail-free card for incredibly difficult airways. We're seeing clinicians combine video laryngoscopy with standard single-lumen tubes, completely bypassing the trauma of a DLT. Grokot's 2018 correspondence emphasized the vital importance of understanding your exact blocker model when navigating these tricky paths. We already mentioned using a Fogarty for subglottic stenosis and extraluminal insertions through tracheostomas, but perhaps the most inventive workaround was reported by Premietti in 2017. They faced a severe, unusual airway problem where an existing DLT was malpositioned and couldn't be safely removed due to swelling. Their solution? They simply passed a wire-guided ARNT blocker straight down one of the existing lumens of the DLT to achieve isolation. Just brilliant adaptive clinical thinking.
Section 5. Positioning, bronchoscopy, and complications.
Let's talk protocol. The absolute, non-negotiable standard for bronchial blocker placement is direct visual confirmation. You simply cannot fly blind here. A Means 2016 RCT made this abundantly clear. Performing a pre-intubation fiber optic assessment in adults doubled the first attempt device placement success rate from 25% to a massive 50%. The sequence is strict. You place it supine, you turn the patient to the lateral decubitus position, and then you absolutely must re-verify the cuff position with the bronchoscope. Gravity and positioning shifts will move that balloon. When placed correctly, the results are fantastic. Cano's 2023 study of 134 clinical cases demonstrated that when blockers are accurately placed in the left bronchus, the rate of excellent lung collapse is significantly, undeniably high, but it all comes down to that fiber optic verification.
Now, even with perfect placement, intraoperative complications happen, and you need to be ready. The most common issue is dislodgement. If that blocker backs out into the trachea, you lose isolation instantly and risk massive barotrauma to the dependent lung. You also have to guard against bronchial trauma from simple cuff overinflation. We also mentioned the unique easy blocker technical failure where air communicates between the cuffs. But what about highly complex pathologies? If you're dealing with a bronchopleural fistula, severe emphysema, or massive hemoptysis, your device selection is critical. In these extreme scenarios, securing a tight blocker seal allows you to safely apply continuous CO2 insufflation or high-frequency jet ventilation to the diseased lung, effectively managing massive air leaks or isolating catastrophic bleeding without contaminating the healthy lung.
Section 6. Meta-analyses, bronchial blockers versus double-lumen tubes.
So what happens when we zoom out and look at the massive, overarching datasets? We have some incredibly robust systematic reviews to draw from. Clayton Smith in 2015 analyzed 39 RCTs, Palashinsky in 2023 looked at over 1,600 patients, and just recently, in 2025, Wu published a meta-analysis of nearly 2,700 patients, alongside Lee's massive network meta-analysis comparing 12 different OLV devices across over 2,100 patients. The synthesized data from all these thousands of clinical encounters reveals a very consistent, undeniable pattern regarding the core differences in clinical performance between these two approaches.
When we map out the forest plots from these meta-analyses, the trade-offs become incredibly clear. Double-lumen tubes reliably provide slightly faster initial lung collapse and undeniably superior suction capabilities. That's a fact. However, the data overwhelmingly shows that bronchial blockers result in significantly less airway trauma. Across the board, patients managed with blockers show dramatically lower incidences of vocal cord injury, tracheobronchial tearing, and postoperative hoarseness. Interestingly, while DLTs might be slightly faster to place initially, once lung isolation is actually achieved, the quality of the surgical field provided by a properly positioned bronchial blocker is statistically equivalent to that of a DLT. The collapse quality is just as good, but with a fraction of the structural trauma.
Which brings us to the ultimate conclusion. Perfectly summarized by Lee and colleagues in their 2025 paper, the selection of OLV devices should be determined by the specific surgical requirements and the patient's clinical status. There is no magic, universal device. The art of perioperative management is strictly bespoke. A massive pulmonary hemorrhage might demand the rapid, absolute isolation of a DLT, but for a delicate pediatric patient, a severe subglottic stenosis, or a difficult airway requiring a videolaryngoscopy, seamlessly deploying an ARNT, a Cohen, or a Fuji blocker is undeniably the superior evidence-based choice.
And as we wrap up this deep dive, I want to leave you with a thought regarding where this is all heading. As bronchial blocker designs continue to rapidly evolve, integrating novel semi-rigid materials and even direct microvideo capabilities at the tip, how will the advent of personalized, patient-specific 3D airway mapping completely reshape your standard protocol for one-lung ventilation tomorrow? The technology is moving fast, and the data is clearer than ever. Thank you so much for joining me to explore this fascinating clinical landscape today.